thousands of questions, and I just randomly pick when I'm setting up the exam, and sometimes they repeat, sometimes they don't. And so, but I think if you use them as just as a study guide, just to, you know, see where you have weaknesses. So if I was you, I will use them just like that. You know, take a look at it. Don't look at the answers. If you know yourself. You should be honest to you and go over. And if there is something you don't know, something you don't understand, then go back to your notes. And then also take a look at, go over your textbook, and also look at, by the way, if we didn't cover it in class, you're not responsible for it. That's as simple as that. It's not there, it's not there. Okay? And so it's just focus on what we have done in class. Every section, I'll try to have as many questions per section as I can. I mean, so try to make it equal for all sections. Okay. Usually expect about 100 questions on the final. Just a double of a regular exam, from 80 to 100, somewhere there. You might get, I don't know, 83, 84. Yeah. And you will have images to identify all those images that we have looked at. So they're going to be there too. Yeah.
That was my question. Are you going to do the same thing?
Plenty.
You have anatomy and you ask us to label them. Okay.
Lots of those.
Lots of those?
Well, no,
okay.
no. I mean, double the amount of what you
all
can
right.
get.
Okay. Thank you.
Mary.
This is not about the final, but I have a question about hip, the lateral hip protection.
The frog leg?
Well, just lateral in general, because I was looking at it in the book, and in my notes I have medial lateral, Lowenstein, and Cornelius, and then modified axial lateral.
Mm-hmm.
But there wasn't like a whole section on just like medial lateral. So is medial lateral like
both of them? No, both of them are, yeah, because if you medial lateral is just telling, that's the projection, right?
Yeah.
So he's telling you that the X-ray is going from the medial side to the lateral side. That's all he's saying.
Okay.
So all of them are all medial laterals. Even the what is it? The Nakayama.
Yeah.
Even that one is medial lateral.
Okay.
Yeah.
So there's only 3 lateral hip projections, correct?
Yeah, the frog leg.
Yeah.
Lowenstein. Okay, and then the axial lateral.
Oh, so there's 4 because there's 2 axial lateral.
Yeah, with
okay.
the if you include as the axial lateral, if you include the what's the first name? The Nakayama.
Yeah.
Yeah.
Okay.
Yeah. But the Nakayama, remember, is not really a true lateral.
Yeah.
It's more of an steeple like.
Okay. Because there wasn't like a page on frog leg.
There wasn't?
No. Unless I missed it.
I think they called it like an AP oblique in the book.
And that was the other point I wanted to make, okay? That in reality, that's not, all of those are not really laterals. Those are obliques, but, I agree with the textbook. Yeah, they're calling it obliques, and that's what they are. It's almost like remember when we did the shoulder? There was the only lateral shoulder per se is the transthoracic. Then there's no really lateral. All the others are AP, internal, external obliques. The Y view is an oblique. I guess the inferior superior, that might be somewhat of a lateral, but it's not really a lateral of the actual shoulder. So, yeah.
Okay.
So, yeah.
All right, that helps. Thank you.
Yeah. Okay. And remember, all practicals, the last practical exam 3 they are all going to be next week, right? Next week is our last week. So, for those of you on Monday, okay, on the Monday left, a week from today, you're taking your practical. Okay? Which means whatever you have left to do, you're going to finish it today. And those of you on the Wednesday lab, the same thing. For us on Friday, the same thing. You have to get it done. Okay. All right? And then everybody takes, you saw it on campus, right? Everybody takes the exam, the final practical exam on Monday. So take a look at, on your syllabus, take a look at the times. I think the Friday group is group 1 and goes early in the morning, and then I think it's Monday in the morning. So take a look at it. Yeah, so going back to preparing for the final, that's how we'll do it. Yeah, it covers a lot. You know, your final will be until Friday, so you have, I know you have other finals to do, but you'll have, at least you have that chunk of time. At least 3 days that you can review. Physics is, when is physics? Wednesday?
Yeah.
Yeah. Okay. Crazy. And some of you are not going to be taking the physics final, right? I hope. Huh?
What? No, we won't take it.
All take. Well, I guess usually what Martin does, if everyone is, if you have someone getting an A or something, then you don't need to take a final. That's, he changed that.
Because nobody's getting an A.
He used to do that. I don't know if he does it. Yeah.
Well, it hasn't been mentioned.
It hasn't been made. Okay, then I didn't say
No
anything.
brought to
You
my
didn't hear.
attention.
Don't bring it up if you didn't bring it. I don't know. Yeah. Anything else? Yeah, great.
On the ankle, I was a little confused too, because on the ankle you have like the AP Mortise, and the AP oblique. On the oblique one, did you want the medial rotation or the lateral rotation?
Medial rotation.
The medial rotation. Thank you.
And you know, I didn't really specifically talk about the oblique. I referred to it just as a comparison to the Mortise, because it's very unique. The oblique, the 45-degree oblique ankle, is done for one specific reason. Okay, and so it's only, it will be orthopedic surgeons asking you for that.
Okay, and as I was going through it yesterday, I saw that on your notes you have put that for the oblique and for the Mortise, you're supposed to relax the foot, not dorsiflex, but on the medial oblique, it says that you should dorsiflex on the foot.
It can go both ways, really.
I just want to make sure
yeah,
that,
no.
I'm just asking because I just want to make sure if you ask that.
Because it doesn't make a difference.
So it doesn't make a difference.
It doesn't make a difference for the purpose that you're doing it.
Okay.
You guys all remember what you're doing it for, right? What's the purpose of the 45-degree oblique ankle?
To open
Okay, it's just that one spot, because you don't see it well on the Mortise or the AP.
So dorsiflexion effects
He's
isn't
not
going
gonna-
to change how you see that.
It's not going to change at all. It's not going to do anything.
Okay.
You're not, it doesn't do anything.
Okay.
So. Okay, anything else? We'll start because we have a lot to do. I have 2.5 lectures to do everything what we need to do. You guys ready? All right, put your seat belts.
Let's
Here
do
we
it.
go.
Let's do it.
You guys enjoyed your break?
Yeah, somewhat.
Good.
Somewhat.
Good. All right, so here we go. So this section, and remember, this one section is only lecture. You're not going to be, there's not going to be labs to practice this. When you come back next semester, RadTech 420, that's the first 2 labs you do are going to be digestive system, okay? So write that on your notes, so don't forget. That's the first thing you're going to do, all right? What we're trying, and I'm sorry, it's confusing like that. This is the way the classes have been organized, and because we've been adding, as time has gone by, we've been adding more material, deleting material here, and adding material that, because our field has changed so much. So that's why we end up with what we are. What we're gonna do next year, I have to present it to the school and see if they agree. I'm going to rearrange both classes. And so what we're gonna do is have this section in RadTech 420, and I'll bring a couple little sections from 420, I'll bring them here. So but obviously that's not going to help you, or that's for the next, hopefully next class, couple classes from now. All right, so here we go. But in the meantime, this is what we have. So this is what we are going to do. All right, so the digestive system, and just to give you a sense, okay, I'm not gonna go over all of that. And by the way, so a lot of the anatomy, I'm just gonna skip it. I'm relying on you and your knowledge about physiology and anatomy for you to go back and review it if you need to, and if you feel like you're fully competent in this section, don't, you know, just, it's fine with me, all right? But I expect you guys to know it. Okay, so I'm not going to go over that. You can do that on your own. What I'm going to tell you, though, is just to help you with your three-dimensional sense. Okay, and one thing to remember is that the esophagus is going to, when you're doing a lateral chest, for example, or you're doing a lateral esophagus, the esophagus is found anterior to the spine, and in between the spine and the esophagus, you're gonna find the aorta. Okay, so there's always a gap. Sometimes people have deformities, and that's, but on the just on the I don't want to say normal anatomy, it's on the usual anatomy, this is the arrangement that you will find. You have a spine, aorta, esophagus, and then you have the heart. Okay, so remember, just kind of remember that. And also remember that the esophagus, when you're not swallowing, the esophagus will collapse. Okay, so it just collapses. Sometimes you might have, not often, but sometimes you might have air trapped in the esophagus. That's common too, but sometimes is you don't see anything. Okay, and so to be able to see the esophagus, you have to use contrast medium. Okay, all right. A few more things. Once again, give you the arrangements of where things are found. And if you see here, the esophagus is all the way here. Okay, it's going to be behind the trachea. Okay, and it's always the most posterior on the superior part of the chest and neck. Okay, it's always the most posterior. And then remember, this is the oropharynx. This is an area where you have an area that is shear. Okay, so it's just at that point it's just one tube. And here, the epiglottis, this is where things spread apart. So here you have your pharynx, and here's the esophagus. Okay, becomes one. Okay, and here you have the trachea. So remember, the esophagus will always be the most posterior of the structures that I'm showing you here. Okay. All right. What I want to show you here. Anything that you see here that you haven't seen before? No? Okay, let's move on. All right, we go back to what we started this class, and we're almost going to end with this, with the different body types. And now the body types also become very important, okay? Because just like the lungs will change in shape and arrangement, the digestive system will also vary, okay, from one body type to another. And so here we have the stenic type, is the more common type. You find it, you know, your typical anatomical setting, okay, where you have the stomach, you have the liver here, the gallbladder, and everything is pretty much, if you have a model of the digestive system, this is what they use. Okay. All right, but not everyone is like that. So you have the hyperstenic. This is the person that is typically wide, and it doesn't mean that is fat or overweight. It just means that it's just their structures are just wide. Okay, and so everything is higher than usual. Okay. Then you have the hypostenic. Okay, where things are lower, okay, than the stenic. And then you have the astenic, okay, where you have everything is much lower than the stenic. Use the stenic as the standard, and then vary it. Then see which, you know. A lot of times it's difficult to differentiate between the hypostenic and the astenic. The astenic typically happens to most people as you get older. It just, gravity takes its toll and everything just descends, okay? And so that's why you might find the stomach all the way down into the pelvis, okay? The transverse column also in the pelvis, the gallbladder in the pelvis, okay? The hypostenic is not so much. It's lower than the stenic, but not to the extent of the stenic. All right, so I'm gonna say, so here are examples of different body types. Here's the hypostenic. You can see this guy is much wider than these guys. See the difference? But sometimes it's difficult to differentiate between these two. What you find here is that this body type just has a much longer trunk. If you see it, if you observe it from here to here, it's just a longer trunk than these people here. Okay. Let's see the differences. Bing. And then the astenic, things are going to be even lower than the hypostenic, much lower. Here I'm giving you a point of reference. Take a look on the hypostenic. Typically you'll find the pyloric antrum at the area of T1, T12. T11, T12, I'm sorry. And then on the stenic, usually around the pyloric antrum again, pylorus will be found around the level of L2. See T9 here, T10 here, where the fundus will be found, okay? And the hypostenic a little lower, maybe about an inch lower, okay, than L3, L4, all right? Okay, good. All right, a few more things about the digestive system. You have accessory organs that help in digestion, and so the liver is involved, the pancreas is involved, salivary glands get involved, okay? And so they are really not structures that are attached per se to the digestive system, but they help in the digestive process. And so that's why I'm showing you here. So you have a gallbladder, okay, here is your common, should be, this is not hepatic. See, bing, maybe. And then here will be the common bile duct, and this is hepatic duct. No, this is wrong. This is wrong. This is common bile duct. This is not hepatic duct. The hepatic duct should come from this side. So erase, see if you have it, erase that. Ding, that's wrong. That's not hepatic. Oh, wait, no, it's fine, sorry. Leave it there, it's fine. Moving ahead too fast. Yeah, common hepatic duct, and then you have common bile duct here. All right, gallbladder, and so they come here, they descend, and they go into the duodenum, okay? Also, you have a pancreatic duct coming here, and here's an orifice where they both combine, okay? You guys remember, it's important to remember this, you guys remember the hepatopancreatic ampulla? No? You guys remember another name for it? There's another name, what is it? I'm trying to remember. Oh, it's right here. The orifice of Ori. Remember that? Yeah, okay, all right. Okay, so it's right there. So that's a hepatopancreatic ampulla, and it's just a reservoir where both the bile and pancreatic juices just kind of mixed, and then they go into the duodenum. Okay, what's the purpose of bile?
Emulsify fat.
Okay, all right. And also, don't forget pancreatic juices also, they help in the emulsification of fat. Okay, so that's what you have here. All right, what else I need to let you know? Remember, the shortest part of the small intestine is the duodenum. But how big is it? How long is it?
A few inches.
What is a few inches? 1, 2, 3. Huh? It's approximately about a foot. Well, not normal size adult, about a foot. So it's not very long. Okay, but it's the widest. It's the widest, but it's the shortest. Okay. All right, a few more things. Let's see. Bing, 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 bing. Here's the duodenal bulb. Here's the curvature. What else I need to tell you? This is, that's it. Okay, that's it. Okay, a few more things. Okay, then you have the small intestine. And when we look at radiographs, I'm going to show you radiographically how you can tell the difference between the different parts of the small intestine. But I have to show you that. Here I can show you, here's the cecum, and here's the ileocecal valve. Here's the appendix. Okay. The appendix is a good landmark. It's always when you're going to do a GI study or BE. It's important to ask the patient if they still have their gallbladder, because the radiologists are always looking for that one structure, because he tells them, okay, now you're in the small intestine, or now you're getting into the large intestine. Okay. Here's the cecum, ascending column. Okay, transfer column here, we don't see it. Okay, here's you have your hepatic flexure, splenic flexure, descending. Okay, and then I'll show you the other components as well. Okay, that when we look at the digestive system, you know, to be able to image the digestive system under X-rays, you need contrast media and also fluoroscopy. Why fluoroscopy? Because fluoroscopy gives you live X-rays, and then you can see movement. As the contrast media moves through the intestines, you can see it. Okay, and so that's why fluoroscopy is needed. Okay, you look at the gastrointestinal transit. You're going to look for peristalsis. And the procedure, okay, as I said, you will need contrast media. You will need a radiologic apparatus. I'm just saying you need fluoroscopy. Okay, you will also need plain radiographs in many cases, and so you will also need an overhead tube. You will need to prepare the exam room. It needs to be set up before you bring a patient in. You need to have the room set up. Okay. You need to also be aware of exposure time. Why exposure time? Why do you think I'm making a point of talking about exposure time?
So you don't want to expose the patient to radiation, and also yourself.
Okay, can you be more specific? Or someone?
You want less exposure time.
When?
Always.
Always. But in this case, particularly why?
Because there's a lot of scattering radiation.
Anytime you're dealing with fluoroscopy, you have to be aware of the exposure time. There is, with the systems that we have now in place, it's difficult to, hardly ever you have the technologies controlling the technical factors. It's pretty much done by the equipment. And so all you can do is minimize the exposure time. Now, do we have full control of it? No, it's the radiologist, but you have to be aware of it. And sometimes you need to remind them. Okay. So anytime you're dealing with fluoroscopy, you have to deal with exposure time. Okay. And so radiation protection also becomes becomes critical. Anytime, not only for the patient, but for you. Anytime, and I'll get a little bit more specific in a little bit. Next semester, next year, we'll spend a lot more time doing radiation protection in RadTech 415 and 430. And then the following semester, you're gonna be doing a fluoroscopy class. And so we'll spend a great deal of time in radiation protection, okay? But one thing that I'm gonna tell you in general, okay? In fluoroscopy, okay? Very important that you protect the patient and you protect yourself. Anytime you're doing fluoroscopy, you have to have a lead shield on you. Why? Because of time. Time in fluoroscopy is not measured in milliseconds like you do when you're doing plain x-rays. When you're doing just plain x-rays, your exposure time is typically milliseconds or maybe centiseconds, okay? So it's very short exposures. In fluoro, you're measuring in seconds or minutes. And so scatter radiation will be more abundant. Also because of the technical factors that you have in fluoroscopy, scatter radiation is pretty, it's abundant. Okay, and so you have to protect yourself. Okay, all right. Let's see what else. And then you also have to protect the patient. Okay, there are cases where a lead shield might be necessary, and there are cases where the lead shield might interfere, and so it's best not to even shield the patient. Okay, it's best not to do that. Sometimes, not always. Okay, sometimes you can. All right, 3 primary functions of the digestive system. Okay, ingestion or digestion, absorption and elimination. All of this, ingestion and digestion, is all done up here. Okay, so by the time you get to the small intestine, okay, you do some digestion in the small intestine, especially in the duodenum, and then once it moves out of the duodenum, now you begin to have a lot of absorption. Okay, and then the elimination is done in the large intestine. Okay, so upper GI procedures. Upper GI stands for upper gastrointestinal procedures. Okay, and so contrast media will be required. Okay, and the purpose of the contrast media is to increase or decrease tissue type, depending on the type of contrast media you're using. Okay, so if you see here, I'm just giving you an example. If you do an AP abdomen, there's no way you can see the stomach. You might see a little bit of air here, but that's not giving you much information, and so that's why the contrast media becomes important. Okay, all right. So fluoroscopy, so you're going to have different type of equipment. How many of you have done fluoroscopy so far? Okay, most of you, okay, have done. And those of you who haven't, you will, okay? The time will come where maybe at the hospital where you are, the days you are there, they don't do much fluoro. But once you become a second-year student, you'll get plenty of fluoroscopy. We don't do as many fluoroscopic exams as we used to. It has decreased a lot because of CT, because of ultrasound, because of MRI. Now, not every person is a candidate to have those exams, okay? And so we still rely on fluoroscopy. All right, just briefly, what we have here, so you have a patient here drinking the contrast media. You have, this is your image intensifier, okay? And these are the controls of the image intensifier. You have here, you have some kind of monitor display where the radiologist can see what's going on. Since it's live x-ray, so the doctor can see and you can see as the patient is swallowing, as the patient is moving, or as the digestive tract is moving, then you can see it here. All right? Okay. Gastrointestinal transit, it's all done because of peristalsis, okay? These are waves that move, okay, intestinal content, moving from point A to point B. Okay, 3 to 4 waves per minute occur in the filled stomach. So as the stomach is filled, on most patients are, not everyone is the same. Sometimes it will take longer, sometimes it will take less.
Can you go back for a minute?
Sure. Ready? Got it? Okay. All right, so contrast media. Contrast media is radiographic demonstration of the alimentary canal requires use of contrast media. I told you that before. Barium sulfate is the most common contrast for the digestive system. Okay, it's the most common. It's not the only one, but it's the most common. Okay. Why barium? Okay, barium is very stable. When I say stable, it means that it doesn't change into other things. Okay, sometimes elements can change, but barium is very stable. It won't change. okay? And it's not absorbed by your body. So you take it in and it goes out, okay? There is nothing, your body's not gonna be absorbing anything, okay? So in that sense, it's ideal. And if you see here, if you look at this periodic table, okay, you find that barium, let's see if I can, we see here, where barium, it's 50, barium, right, 56, okay? And so it's ideal, okay, because it has a high atomic number. And what does it mean? Or it has a higher atomic number than any other element in our bodies. Okay? What's the highest content that you have in your bone? What's the element that you have the most in your bone? Calcium. Okay. And if you look at calcium, I mean, where's calcium? It's 20. That's the highest element. Your teeth will have a lot of calcium too, but it's 20. Okay? But barium is a lot higher. And so you see the difference between the atomic numbers? And so X-rays are absorbed much better by a higher atomic number. Make sense? So that's the ideal. Next semester, once again in 415, I'll go into all the details of why it works. But for now, just remember that because it has a higher atomic number. Are we good? All right. If barium, okay, is not, sometimes barium is not ideal. And it's not ideal when or if they suspect a bowel perforation. If they think there is somewhere in the intestine you have a perforated bowel, they're not going to use barium, because barium is so stable that it will never leave your body. Okay, but it will cause an infection because it has gone through your GI tract, and so it becomes very serious. That means they have to operate on this patient, open up the patient, clean up where barium is, okay, get it out, and massive antibiotics, okay, and then close the patient again, okay? But also, what's the meaning if you have barium is moving out of the bowel? What is the medical significance if barium is sneaking out of the bowel? If you have a perforated bowel and it's sneaking out of the bowel, what is that also saying? Huh?
Is it in your blood?
No, it's not. It's not absorbed. And see, that's the beauty of barium, that it won't be absorbed by your blood system. What it's saying, if you have an opening, if you have a hole there, is that fecal matter is also moving out. Okay, and so that's why the nasty infection. Okay, because now your peritoneum, your peritoneal cavity will be filled with bacteria, right? And so that's why they don't want to use it. Okay, it's a bad thing. Okay, because once it's a bad thing. Let me put it this way: it's a bad thing because if barium sneaks out, barium will not be absorbed by your circulatory system. It can be absorbed by your tissues. It just sits there. Okay, and so that's why they have to open the patient up and go and clean it. Okay, and so if that's the case, okay, if they suspect a perforated bowel, what they do is they use water-soluble iodine. Okay, and if you look at iodine here, you find that iodine is 53. Yeah, iodine is 53 right there. So it still has a high atomic number, higher than anything, any organ in our body. Okay, so still it works well, and the advantage of it is that it's water soluble. So what is the meaning of it? If it is water soluble, what's the significance? It will be absorbed. And so if, say, let's imagine that the patient had a perforated bowel, contrast media sneaks out of it. Okay, they don't have to operate. They might, because they still, if there's a fecal matter there, they might need to go in. They might just treat it with antibiotics, but they don't have to go in and try to look for where the contrast media is found, because the iodine will be absorbed. Make sense? So that's the difference. So if a perforated bowel is suspected, then iodine will be used. Okay? Now, how come we just don't use iodine before every exam, because it is water soluble, it gets absorbed, and if you wait too long, it will be absorbed. You're not gonna see it in your intestines. Make sense? In addition to it, because it's incorporated into your circulatory system, patients can have a reaction to it. That's not the case with barium, because barium is just going to a tube inside our bodies. It's never absorbed into the circulatory system. See the difference? Okay, that's at least 5 questions there for your exam. At least. All right.
What are the symptoms of a perforation?
Patient will have a lot of pain, and it's just a pain.
In the abdomen?
Yeah. And sometimes it's not so easily identified. Remember when we studied the abdomen, I said, look, this is free air. That's what free air was telling us, right? A lot of times you don't see free air. A lot of times you have to give the, if you see free air, then you know the patient has a perforated bowel. You leave it at that, and then you try to find out where it is. If you don't know, then they might move on to an exam like this and see see what happens. Okay.
So for if a perforation exists.
And also, sometimes if someone has, someone has a perforated bowel, you might have a fever if the infection has already taken place. Yeah.
To rule out perforation, they're going to be using water-soluble contrast to find the hole, right?
Okay. All right, let's move on here. So contrast media, iodinated solutions move through the GI tract quicker than barium sulfate. Clear the stomachs in about 1 or 2 hours. Okay. Barium might take a little longer. To clear the stomach, it depends on every patient, guys. Okay. Some patients, especially children, they will move contents like that. Quickly. Within minutes, it'll be empty. But with adults, and when I said empty or clears the stomach, that means all of it has come out. It might take this long, 1 or 2 hours, just to leave the stomach. Iodinated solutions do not adhere as well to the esophageal mucosa as barium sulfate. So here's another advantage why barium is also better, because it's thicker, it's heavier, it sticks to the walls very well. You can see the lining of the, not only the stomach, but the whole GI tract much better. Iodinated solutions provide satisfactory examination of the stomach, duodenum, and large intestine. And that's all I'm saying, it's just satisfactory. It's not perfect. Okay, it's not great like barium is. All right, a few more things about contrast media. Water-soluble media easily removed by the aspiration before or during surgery. There you go. Barium is very difficult to remove. Also readily absorbed by the body and excreted by the kidneys in case of perforation. I mentioned that before. All right.
You go back?
Sure. Yep. We're good? Everybody? Good. All right, so this barium can be presented in many different ways. A lot of times, and it depends on your facility, depends on what they buy. Sometimes it can be, they can buy it as a powder, and then you do the mixing. You add water, specific amounts of water, and then you mix it, and you can get, you can get your barium. A lot of times they just buy it. They buy it already pre-made. All you got to do is shake it. Okay, remember to shake it, because if you don't, then barium will sit it because it's so heavy. This is an emulsion, so you don't have a complete mixture of both barium and water. So if you leave it sitting there for days, then barium will settle at the bottom, and so that's why you have to shake it really well. Okay, so this is called any type of contrast media where X-rays are going to be absorbed is called a positive contrast media, or radio-opaque, which means that it's going to be absorbing X-rays. Okay, and it's going to on your in this case, in the case of barium sulfate, it's a chalk-like substance, and that's how it tastes too. It absorbs more X-rays in comparison to iodine. And this is the formula that is used. It's barium sulfate, okay, SO4. Okay. There are different types of suspensions for different studies. Okay. So you see brand A, brand B, brand C, brand D. And what you have is just different. You have different thicknesses, and you have different
Grades?
yeah. How can I put it? How well it mixes with water. You'll have differences, and sometimes you want this, sometimes you want this. It depends on the study that you do. Never really dissolves in water. Remember that. It doesn't dissolve. It's just mix it with water. Okay. That's why it's called a suspension, because it's only suspended in water. If you leave it there 4 hours or days, eventually this will happen. Okay. The rate of separation varies with the brand. Okay. Contraindications: perforated viscous. This means perforated bowel or pre-surgical procedure. Okay. These are going to be the contraindications. All right. Sometimes you might use something that looks more like this. It looks more like a paste, okay, like a toothpaste. It's very thick, and you use it when you want to coat the lining of the esophagus, for example, or you want to coat the lining of the stomach. This is what you use, okay? And thin barium, when you have a 50-50 ratio or a 1-to-1 ratio barium sulfate to water, this is more for general studies. If you want to look at just a general study. When thick barium is used, you combine it. Typically, you combine it with air. Write that down. I don't see you writing that down. You have to. Okay.
Can you repeat that one?
Yes, I'll repeat it again. Okay. Typically, when you use thick barium, you will mix it with air. Okay. You might use this, a little bit of this, and then you use air. So you can have something called the double contrast image. Why double contrast? Why is it called like that? Because you have air. Air is your negative contrast media. We talked about it in RadTech 400, remember? Yeah, right.
That makes more sense.
Yeah. So you have double contrast, meaning that you have positive contrast media, the barium, and then air is negative contrast media. Okay? All right. Are we good? All right. All right, now let's talk about, so we're done with barium. So now let's talk about iodine. Okay? Iodinated contrast media. This is just a brand. Okay? This is just an example I'm showing you. In this case, it's called Gastroview. Other brands call it Gastrovis, or Gastrographin. There are different names given by different brands. Okay? And so what you have here is iodine. Just think, I mean, the main component, what we want to see is iodine. Now, they add all of these other components, they add it there so it's not so toxic to the patient. Okay? Make sense? And iodine can be many people will react negatively to iodine. They will get hives, they can get a heart attack from iodine. And so they mix it with other things to make it more not as hard on the patients. Okay? Make sense? Okay, so. All right. So, and as you can see here, not for parenteral use. That means that you can only use it for the digestive system, not for anything else. Because you can have other type of formulas that can be injected on the patient. This is not to be injected. This is not to be, this is just for the GI tract. Okay. Indications. This is for perforated bowels, pre-surgical procedures. Contraindications, hypersensitivity to iodine. Okay, if someone is allergic to iodine, probably won't do well with this. All right? Huh? You ask the patient. Ask them and see if they are sensitive to iodine. Okay, many people, you know, they will know. If not, you will find out. Yeah. And it's not so much of a problem when it is given orally. The problem really is when it's given intravenously. Then it's a problem. Okay. Have I seen patients react to oral iodine? Yes, but I can probably count it with one hand how many cases I've seen. Intravenously, I need probably all your fingers. And toes too. It's more often and more severe. This is not, hardly ever happens. Okay, so single GI contrast media, double contrast. So here you can see when you have single contrast media, it's just a barium, okay? Just a barium and a little bit of air that you might have already in the bowel. When you have a double contrast, okay, now you can combine barium and air and see the coat, how nicely coat the rugae of the stomach is. Okay, so that's what happens. So, it depends on the radiologist. Depends on what they're looking at. They're going to ask you for single contrast or double contrast. Okay. Yeah.
How do you mix it with air?
We'll talk about it in just a bit. Okay. I'll just tell you now. Different ways. What most hospitals will do now, they will use sparkles. They will use seltzers. Okay, that will just blow up when they get, not blow up, I mean they will just, well, they do blow up air. Okay, they do blow up air when you take it in. Once you put it in, they just pop and they give you a bunch of air. Okay, or what we used to do, there were a couple of radiologists, they will put a needle in the straw. And so when the patient swallows the barium, they are also swallowing air. So that's one way of doing it too. But the most common nowadays, and it's the easiest thing, is to just give a sparkle. So you have the patient put them in the back of the throat, swallow it with a little bit of water, and then they expand in the stomach. You don't want them to expand in their mouth. Then they're going to start. You have saliva everywhere. Okay, so
they take the little sparkles and then wash it with water, and then they drink.
And then the barium, boom, 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 very quickly. Yeah, and then you tell the patient, don't burp, because their stomach is going to be filled with gas. Just like when you have a carbonated drink, right? You know, especially when you first open, I don't know, your Coke or whatever, you drink it and then boom, and you right? So same thing happens. So you tell patients, don't burp, because that's what you give the sparkles for. All right, let me finish up this section, then we'll take a break. Mucosal folds are demonstrated when you have double contrast medium. That's the nice thing about double contrast medium. You can see all the small details, okay? Like in this case, the mucosal, the rugae, can be seen here. Okay? When it's single contrast, you don't see that. So it depends on what they're looking at. Okay? Depends on the pathology. Here's, see how nice it looks? Here you go, more examples. Bing, 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 bing. Equipment, talked a little, I already talked. You have your image intensifier, you have a table, and fluoroscopy tables, they need to tilt. Okay, and remember from Tech 400, we talked about that's how you identify tables. 3090, 2090, okay. 20, the first number tells you that now the patient goes in Trendelenburg, okay? And the 90 tells you can bring the patient upright. Because there are many GI studies where you need the patient standing up so you can see how the contrast media moves, especially when you're doing the esophagus. You want to see it move, okay? We good? Okay, good. Any questions about the picture? No? Okay. This is probably an old, probably 80s, 90s piece of equipment. Okay. Yeah, but I mean, the purpose is the same. Okay. Oh, one thing I forgot to also mention, your radiographic table will be equipped with a footstool. The footstool is there so you can have the patient stand up and you can move the patient up and down so you can see the esophagus, you move it up and then you can see the stomach and vice versa. Okay, this is more like what a newer system will look like now, where you have, they work the same, okay, they work the same. The big thing here, you still have an image intensifier, you have a overhead tube, oops, sorry, and you had an overhead tube here somewhere here, it's right here. You have hiding, you have your overhead tube. So you have flat screens, but the physics of it is the same. It's exactly the same. Okay? It's just newer. It looks nicer, but they do the same thing. All right, and we'll ignore this. It's the same thing. I'm just saying that this is computer-based, where you can. It's all digital, and so you can. And digital doesn't mean that you need to have a flat detector. You can still have the image intensifier. The signal is sent to a computer, and then the information is digitized. What is nice about a computerized system or a digitized system is that you don't have to necessarily use any type of cassettes. Okay, you don't have to. You can do multi-framing very quickly, and then after the image, this is the great advantage. Okay. The great advantage is after the image is complete, you can manipulate the image, okay, without re-exposing the patient. Now, this is the most modern systems. Here you have a flat detector. See, no image intensifier. This big hat here on the equipment, you don't have it here. This is a flat detector. It's a DR system, and so everything is done from the moment you acquire the images. They are digitized. So no special processes. With this system, you still have to do a little processing before you send the signal to the computer. Here you don't have to. We don't, on general fluoroscopy, we don't see too many flat detectors yet because they are very expensive. Very expensive. And so hospitals are still waiting until the prices go down. But we do see flat detectors in angio. In angiography and cardiac cath, you do see it because there are many advantages that we'll talk about next year. All right, let's stop here. Take a break. Come back at 9:15, please.